All right. So try falling down and scraping your knee. Then you can talk to me about pain. Um, so I think in terms of, what are the large goals in terms of coming up with adverse event reporting plans for clinical trials? Again, identifying safety concerns. A lot of this in drug trials is finding if there are new safety concerns from a drug or quantifying the existing known safety problems to potentially exclude safety concerns, to contextualize risk, and to comply with regulations. These are some of the, again, this is a lot largely couched towards drug trials, but really applies to lots of different studies involving clinical trials. And, some of the major ways to potentially measure the safety is, again, on the primary outcome measure, negative efficacy in stroke. This is one of the things where if you have an adverse event that leads to neurological worsening, that's going to be exerted on the modified Rankin scale. But there are other types of safety outcomes that may not be measured on the primary efficacy scale. And then monitoring the adverse events to see how often those are occurring. It can help to predefine some safety outcomes. On one of the clinical trials that I am working on for benign positional vertigo, we are trying to quantify whether anything serious occurred from doing the Dix-Hallpike, like a vertebral dissection or a stroke from that. But that would be something we would really want to know, which would mean that we perhaps taught the Dix-Hallpike poorly, but we don't necessarily expect that to occur because you'd have to do the Dix-Hallpike test really fairly aggressively to exert that sort of adverse effect. Lots of regulations are out there, and again, there's some overlap on these. I think another key thing is that sometimes these are called adverse occurrences, adverse outcomes, effect, experience, or reaction, a drug reaction, adverse drug reaction. This is any untoward medical occurrence in a subject, potentially symptoms. Each separate event ought to be reported individually. It's important to realize that an outcome is not an adverse event. So if you die, that can be the result of an adverse event, or it can be the result of a pre-existing condition, but the adverse event itself is not death. You can have sepsis that leads to death, for example, but death in and of itself is not necessarily an adverse event. Sometimes in stroke trials, people will die, but they had such a large stroke that the death was potentially secondary to the pre-existing large stroke. And again, that's, a lot of times though, there's some philosophies on that you have to come up with something. So cerebral edema leading to death as the consequence of stroke, since the cerebral edema wasn't pre-existing. So that's worsening of that stroke potentially. The seriousness is, again, a measure of what sort of impact it could have on the patient. And expectedness is potentially something that you want to have a sort of predefined algorithm to handle that's relatedness. So expectedness is this idea that, are we going to experience nausea with certain types of agents, potentially? The relatedness, potentially, something is not related, that the timing is wrong and there was clearly another cause. Unlikely, possibly, probably, indefinitely. Again, this is something that in the templates is good to predefine in your protocol and your human subjects plans for NIH grants, how you're going to assess relatedness and who is assessing relatedness. Again, this is the severity of the event, which is, as Dr. Silverwhite points out, sort of unrelated to seriousness. And I think, again, not to belabor these points, that's a lot of what he had gone over on that talk. So I will unshare my screen now and just open things up broadly to all of the participants or other faculty for other thoughts or questions. I think at this point you've probably all been muted, but you should have the ability to unmute yourself unless you're on the phone. And I think Joy, do you remember there's a number that they can press to unmute themselves if they're on the phone, right?
Yes, but I'm uncertain of what that is. I'm sorry.
Okay, if you're, I think the one person I see who's exclusively on the phone is in the 617 area code. If you need us to unmute you, send us an email, and we will unmute you. But from that, all right, I'm opening things up for questions, and if you are. Oh, did I say six? Oh, it's pound, like *6 unmutes.
Yeah, I think it's *6, sorry.
Yeah, I think that's what it is.
All right. Okay, well then, nobody seems to be talking, so I'll unmute it. Should I unmute it? Is anybody trying to talk and unable to? If you put something in the chat room.
One of the questions that came out of our small group is, what is an acceptable adverse event? I don't know if you want to talk about that. So if you have a disease, I don't know, maybe this is, I'm just trying to get some discussion going. So
I think maybe what you're saying is, does it depend on the context? That a adverse event, like if you're agranulocytosis, which would be bad pretty much for everybody, but a small risk of agranulocytosis may be acceptable for a disease that is extremely serious and hard to treat, maybe a degenerative disorder or ALS. Whereas if it's a drug, if it's a disease that has lots of different treatment options, like perhaps migraine, then having such a dire potential adverse effect, at least in the sort of as potentially common, could be a big problem. And I think that's true. And I think that's something that comes up a lot in terms of, the sort of general question of what are the toxicities of the intervention or the drug in question, and whether those are overall balanced with the potential benefits of the intervention. And I think that's sort of a broader question between sort of balancing benefit and risk of any intervention. If you anticipate adverse events because of knowledge from other diseases or other uses of the treatment, like immunosuppression is commonly used for a variety of conditions, and it has some well-established potential adverse events. So those are things to consider. So I think the context absolutely does matter. Let's see. Other questions?
So a little off topic.
Yeah, we can take questions on anything if we.
Well, it just is a concern that was brought, because I just came from my small group, is that the budget template apparently isn't working on the website.
Oh, the
The
budget
budget
template that came across?
template that is in the syllabus. When you click on it, it takes you to the website, and then it doesn't work. I haven't tried it myself, but 2 people said that. So maybe we just need to check that.
Yeah, we were troubleshooting one of them before. There was an older link that I updated, and I know that we I think that's a good question.
Maybe you could just put that out to everybody, the new link.
Yep. I think I can, after we're done with this, I can find the link.
Sorry, that was a little housekeeping.
I guess, have people been able to get into there's also the link to the shared box folder that has course materials, including the sample grant. I've sent that's available in the syllabus, and once you log into it, I think once it should start showing up in your box folders. Have people been able to get into that? Because then there's an example budget there. So I guess, well, there's a question. Okay, can you talk about the scope of adverse events that need to be captured and reported? I've seen papers that reported common cold as an adverse event and a behavioral intervention. It was obviously not related to the intervention, and I was confused about why this was even being reported. Is that necessary? So it depends. It depends on the area. It depends on what, if any, if you're in a space where you're doing a drug trial, definitely would say that a case of the common cold is unlikely to be related to the behavioral intervention. If they had, presumably they had some sort of plan, and I don't know, it's possible that the behavioral intervention could not be definitely not related to the cold. If the behavioral intervention involved seeing other people, like exposure to other people is a risk factor for developing a cold. So if the behavioral intervention is being tested against staying at home playing video games and being sedentary, then you could make an argument that the common cold might have been partially related. But I think the other part of that is that a risk that is elevated over just sort of like baseline living on Earth, in that any sort of social interaction potentially puts you at risk for developing a virus. So it's probably not necessary for most studies, and a lot of times but sometimes, again, it's one of those things, particularly for drug studies, they have to cast a pretty broad net. Like, I participated in a drug study of an acute stroke treatment of a eptifibatide plus TPA for stroke in a study called CLEAR. Art Pancioli in Cincinnati was the PI, and we had somebody who was hospitalized. There's 90-day follow-up. The patient gets a drug infusion, within an hour, basically for the first hour they're in the hospital. But then things that happen during their 90-day follow-up period are potentially adverse events. So if one of the patients had a cholecystectomy because of cholecystitis, in day 80 before their 90-day follow-up. So that was a adverse event because they got hospitalized for it, but it was clearly unrelated. And in terms of how papers tend to report unrelated events, it's it can depend on your setting, but you want to be transparent about it, and you also want to make sure that there is a reproducible guidance that you're using to be classifying things. And whether or not, but we didn't do active screening for whether people had colds and stuff at the 90-day visit because they were no longer being exposed to the intervention. So now if you're giving somebody something, whether it's a behavioral intervention or a drug, every day or every week, there may be some screening questions that you would be doing over time that you would be asking for. And Charity and our group had brought up some cases of people who are on exercise interventions. So some of those can involve discomfort in your muscles and so forth. And that was screened for, if I recall, using open-ended questioning. So that's one example. So sometimes you wouldn't necessarily, you may or may not report things like that, the common cold. It would just sort of depend on how you are screening for adverse events, whether it's more of a sort of passive surveillance, like have you been hospitalized for anything, since your last visit in the study, and if somebody, and sometimes it's defined as anything. Sometimes there's also definitions that if a person goes to an emergency department, it's considered a potential adverse event, even if maybe you or I wouldn't have gone to that emergency, an emergency department for something like that. So, but again, that gets down to having a transparent and reproducible way of attributing whether there's a likely relationship to the intervention. So I don't know. Any other thoughts on that, Lori? Your thoughts on how you might kind of think about categorizing things into things that you ought to be out there looking for versus sort of random noise of life that kind of sneaks its way into the reports of adverse events?
I mean, I think adverse event reporting is, different than serious adverse events, like you said. I mean, I think you covered most of this.
I guess the one other thing I didn't cover was it was on the other side of the severity scale. In patients, for example, in studies of people who've had cardiac arrest and neuroprotection after cardiac arrest, like the TTM trial, there was basically 98% of the patients in both the control group and the intervention group had serious adverse events because they were in an ICU. Now, were those serious adverse events necessarily related to the, different targets for temperature management? Probably not. And given the high rates in both populations, it was, basically, it was as safe as an intervention as there was. But you can also get into a very high noise environment where you have sick ICU patients, where there will be basically multiple serious adverse events within an individual in all likelihood.
I think the other thing is, we talked about this in our group, is that if you have a large number of, minor adverse events, but their cumulative effect is that the patient causes increased dropout, right? Then that would be another reason to be collecting all those other adverse events. Does that make sense? So, for example, if you have, if there's just a little bit of nausea, but there's also a little bit of rash, or a little more frequency of the common cold, or whatever it is, it's not enough to be a serious adverse event, but the cumulative effect may cause decreased tolerability. People may drop out of the study. And if you're trying to explain why more people drop out, it might be useful to see that those adverse events. So.
And there's, oh, sorry, Lori, keep going.
No, I'm done.
Yeah, and sometimes the adverse events can lead to potential partial unblinding if it's if it's something that is, if it's a placebo study, then and a drug has some known effects, then people may or may not be partially unblinded by some of those effects, although you can have adverse events with placebo. And again, sort of that sort of noise of daily living, it's like, if you read the package insert for any drug, including, ibuprofen or Tylenol, there are, all these adverse events, but then, it does lay out how many of them were experienced in the placebo groups as well. So you get that sense as that's the background noise in the population that was in those studies. I think, so Ram Narayan has a good question. He's doing, oh wait, just before I go on to that question though, did any of the other faculty who were in the room have any other questions or thoughts about stuff that's coming up?
So this is Charity. Can you hear me?
Yes.
Okay. When we were recently exploring this topic about patients who were having surgery for a multi-ligament knee injury, I found a paper, and I'll figure out a way to share it with everybody. Reporting adverse events in a surgical trial for complex congenital heart disease is from the Pediatric Heart Network experience. And they really did a deep dive into what should be reported because of the complexity of the patients in terms of how sick they are. And I had a really good discussion with the NIH program officer that worked on that paper as well. And so I'll put it out there in case people want to review it, because it gets at this point that you're talking about, Will, in terms of the noise, for patients who are incredibly complex with their sickness. So I'll put it out there for people to review.
Great. Any other faculty have any other thoughts? All right. I will move on to, this is a good question, the potential risks and benefits of doing a driving simulator. If the risk attributed to the simulator is you might get, nauseated, or you might get simulator sickness, I think that is, since there's not a persistent, there's nothing that's really persistently being conferred by the driving simulator in terms of a lasting effect. It would not seem that there would be a long-term risk of the simulator itself. Now, it's possible that people will have other issues that might be, that might come up, whether they, sometimes you're going to have something that's unanticipated. If somebody gets, I don't know if a headache would count as simulator sickness, but somebody might just get a headache induced by the simulator. Maybe somebody could have a seizure during the simulator. Again, if somebody just went into, depending on whether they had epilepsy or not, if somebody had a seizure while they were in the simulator, that might not be something that you would predict. But if it had a potential temporal relationship, that would be perhaps a novel toxicity of the simulator itself. So you would say, I think when you would be like describing, it could cause anxiety if the simulator, again, and Ram is doing a project where he is looking at doing a potential driving simulator to help assess for and improve the driving abilities of MS patients. So it's, potentially, you have to talk about, so there's some aspect of this is like in the consent form, talking about the potential risks, the potential benefits. As Lori, points out, you could have anxiety or stress from this. So again, I sort of wanted the simulator to sort of ramp up and get harder and harder to sort of, get people, potentially you are going to be inducing some stress and anxiety. It's different though, because I know that it's simulated, so it's not the same as, pedestrian, jumping in front of you and those sorts of things, but you may be exposed to some of those things during that would be unpleasant during a driving simulator. And I think ideally the driving simulator ought to expose you to some unpleasant situations. So, I think now if it's the, at some point that, that might be, it may be, even though it's intentional, it's like people will have some minor increase in their stress. Are you going to ask them how stressed out they are during the driving simulator? Maybe. I mean, if people are getting really anxious about it, that might dissuade people from coming back for future sessions. So as Lori was pointing out before, thinking about the adverse events and experiences within the context of how they might lead to differential dropout, I think is important. All right. Any other questions? And it can be at this point, we haven't gotten this is one of those things where it's important to start thinking about these things in terms of how you want to collect things, but it's also just important to think of how you're going to scale and contextualize things. And particularly in your own single center studies, whether or not you have an external medical monitor, you may or may not. So again, the PI may be classifying these things. So you want to make sure that you have in larger and multi-center trials, you would have an independent medical monitor or an independent medical officer of some sort who would be looking through to help classify the relatedness and those things. But in your early studies, you may be the one who's classifying the relatedness. So having a schema as to how you're going to do that so that others would come to the same conclusion as opposed to simply saying, that's clearly not related. But again, collecting broadly, particularly if it's a single center study, but then classifying so that others can look and see what you might have classified. So Dr. Freitas has a good question. Patient is discontinuing a study drug due to the AE. Should we try to convince the patient to come for the rest of the visits till the end of the study to collect data? Yes, definitely. You would want to encourage them so withdrawing from the study intervention and withdrawing from the study are sort of separate. So discontinuing the intervention, it would be good to collect their follow-up data and potentially important to see that their adverse event resolves. That's another thing that's sort of key, when did it start and when did it stop? And that's something you want to make clear in the consent process, that if you need to stop taking the drug, that's okay. We would like you to keep coming as well. And that's something that IRB templates are usually pretty good about for that. But that's a good question. You would want them to try to convince them to stay. That would be definitely the best practice there. Well, it's August, and in just 2 weeks you'll be here in Ann Arbor. Hopefully it's not as hot as it is today. It's like about 90 degrees. I know some of you are from places where it's routinely 90 degrees. Not necessarily routine here. All right. Well, was there anything else anybody wanted to ask or kind of throw out there? I see something else popping. Oh yeah, here's Joy has popped up the evaluation for this session. Yeah, I think we have the website's in a couple different places. I think we do have an updated link for that, which we will fix it on the website, but send something out to the participants with that link. And I think with that, that's all that I had to cover. Next week, we have a great webinar on study drug formulation and supply, and that will be good. And I think I would encourage you, even if you are doing a non-drug study, you may be doing a drug study at some point in your career, hopefully as a budding clinical trialist. So I would encourage, if you can, to attend that. And with that, I don't have anything else for today. So I think we can adjourn a little early. And it was great seeing everybody.